This program is made possible by PSCA, the Plan Sponsor Council of America. For over 60 years, PSCA has served retirement plan sponsors through education, advocacy, and research. Information at psca.org or at 312-419-1863.
Welcome to this episode of Money Sense. I'm your host, Anthony Contrucci. This week, we'll be covering long-term health care.
According to the AARP, the lifetime probability of becoming disabled in at least 2 activities of daily living or of being cognitively impaired is 68% for people age 65 and older. And the U.S. Department of Health and Human Services says the number of individuals using paid long-term care services will reach 27 million people by 2050. My mother, who is 92, lives at a long-term health care campus. She made that decision on her own a few years ago, and as the oldest of 6 children, it has provided us with the comfort of knowing that when she needs help, it's right outside her door. It's been one of the best decisions she's made in her later years, and she's so happy there that we have all decided to make the same move if we are fortunate enough to live the long life she's led. I'm glad my mother was financially able to make this important move in her life, and I'm already thinking about my finances to ensure I have the same option available to me. Have you thought about your future or the future of your loved ones?
Today we'll be talking with 2 amazing women. Eileen Dunn is a geriatric care manager assisting families struggling to care for aging loved ones. And Nicole McAllister is the business office manager for Franciscan Communities, St. Anthony campus, a senior living community in Crown Point. Welcome, Eileen and Nicole.
Thanks for having us, Anthony.
Glad to be here.
Yeah, well, thank you for being here today. I'm really excited about this topic. You know, on Money Sense, and as you know, in today's day and age, we talk a lot about living longer and how that really is an issue. And in fact, we've named a risk after it, you know, longevity risk. So this is something I think is going to be near and dear to many of our viewers' hearts. So let me kick it off with you, Eileen. You know, we've heard the term long-term care. What is it?
Long-term care, really, it means when someone needs assistance, and I mean standby assistance, which means someone within arm's reach, with these tasks called activities of daily living, often referred to as ADLs. And there are 6 ADLs. There's bathing, dressing, eating, continence, transferring, and toileting. And toileting is not nearly as offensive as it sounds. Very often that's just assistance getting to and from or with clothing adjustment.
Interesting. Now, I'm sure, like with many of the topics on Money Sense, there's a bunch of myths or misconceptions. Are there a couple you'd like to highlight?
I think 2 of the biggest myths are, number 1, that long-term care is just for old people or it's for end-of-life care. And the reality is 43% of all long-term care is provided to people under the age of 65. And the second myth is that it's about nursing home. You know, as a care manager, I'm there to help people stay at home. And most people go to the nursing home as a last resort. People want to stay at home. So this is really about nursing home avoidance.
Interesting. So what I heard you say is, at the end of the day, there's a couple of different options already that I didn't realize that the stay-at-home option was really so prevalent, and then obviously, physical facilities. So what are some of the options for people out there, whether they be the elderly or younger individuals that need this assistance?
Well, there's, basically you have to pay for assistance, you have your primary health insurance, you'd pay out of your pocket, or you have private insurance, such as long-term care insurance.
Nicole, what are some of the costs associated with, with all these various options? Can you maybe walk us through that a little bit?
Yes, in the home care, the average wage per hour for that is like $20 an hour. There's also independent living, which is less care, and the cost related to that usually requires like a partially refundable entrance fee, as well as like $1,800 a month. Assisted living, which is a little more care, with different packages, runs around $4,000 in the area, and long-term care can run as much as $7,000 a month or more.
Wow. So, I mean, it's really across the board. It can be relatively inexpensive to pretty expensive. So, I mean, I guess, Eileen, maybe back to you. How do people, what are some of the funding options out there?
Well, again, the primary health insurance, there's a misconception, I think, about primary health insurance. That's primarily about treatments and diagnostics. You go doctor's appointments, testing, but it doesn't pay for the care that you need because of that diagnosis. In other words, the care with those assistants with the ADLs. Then you can pay out of your pocket, which of course gets it to be pretty expensive. Very often for home care, what most people need is a few hours in the morning and a few hours in the evening. But that's 6 hours a day of care, and that could be $30,000 to $40,000 a year. And then of course you have private funding options, which primarily would be long-term care insurance. There's also some life insurance policies available with long-term care riders. But in Indiana, you have something called the Partnership for Long-Term Care, which is a long-term care insurance program that offers asset protection. So that's a great option for people to consider.
You mentioned Medicare in that last answer. I mean, doesn't it cover most or some of the costs?
Now, under Medicare, you have to require what we call a skilled service. And that's anything that requires a licensed professional, like a nurse or a physical therapist or an occupational therapist. Very often, I'll have clients that will go home from the hospital that might need a nurse to come out for a couple of weeks, but after that, they don't need the assistance anymore, which means any home care services stop. So most people don't need hands-on care. And the skilled service also requires that hands-on care. Most people need standby assistance.
Okay, interesting.
And unfortunately, when you need care, it has to be paid for.
Eileen, you know, I've heard a lot about primary insurance. I've heard a lot about, you know, Medicare. Are they one and the same? Can you maybe provide the backdrop on that?
Well, they're very similar. Medicare was designed to replace your primary health insurance. In fact, when they created Medicare in 1965, Blue Cross Blue Shield was the primary health insurer. Blue Cross is for the hospitalization, Blue Shield is for the doctor and the outpatient. So when they created Medicare, they said if we base this on a program that people are already familiar with, it'll be easier for them to understand. That's why we have Medicare Part A that's for the hospitalization and Part B that's for the doctors and the outpatient. So that tells us that Medicare was designed to mirror primary health insurance, and that's why people go, you know, from age 64 to 65, they just transition to Medicare.
Interesting. Nicole, what are you seeing in your world with regards to obviously primary insurance and Medicare?
In my world, we primarily see Medicare. As of late, we're seeing a lot of Medicare Advantage plans as well, which are kind of the same thing. But they are utilizing those benefits if they enter through skilled care. But once that's finished, they're at a point where they have to make a decision whether they have the ability to pay privately or file for Medicaid. That they're traditionally only here 33 days, or only in skilled care for about 33 days, when everybody kind of looks at this as a 100-day benefit. They don't always get that. They have to show progression. They have to show the need for those continued services to utilize those services.
And that's that skilled service that we were talking about earlier. Under Medicare's always attached to a skilled service.
Absolutely.
So you're saying your average day of care is really 33 days covered under Medicare.
Correct.
That's a big myth for
That's
people.
what we see. Exactly. There is the Part B component, which is once they leave the skilled care setting, they can use Part B, continue to use Part B for their physician's visits, for therapy, for all those outside medical tests, which are diagnostic. And then they have a supplementary often that helps cover those costs. But after that, room and board is not covered. And that's where they're left with a decision whether or not they can pay or, you know, need assistance filing for public aid.
Interesting. That's what I like so much about Money Sense, is that it gives us this platform to talk about these major misconceptions and myths, right, that are out there. So this is powerful. This is exciting stuff. Eileen, I've heard the term now throughout the course of the show, just hands-on. Is most of the care typically hands-on? Can you maybe speak to that a little bit?
Well, I know in my world, and certainly in the home care setting, it's mostly standby assistance. Again, that's someone within arm's reach. Okay, hands-on care means physical assistance with the task. And just as an example, bathing and dressing are usually the first two ADLs that people need assistance with. And they're the easiest to manage in a home care situation because they can be scheduled. Under Medicare or primary health insurance, you must require physical assistance with the task. Standby assistance, we help someone to the shower, we close the curtain, they hand their robe out, they wash themselves, they turn the water off, we hand the robe in, we help them out. In that case, their dignity is maintained and their privacy, but they're also able to access services when they're still at a higher level of functioning. If you have to wait till you need hands-on care, you've deteriorated, right? And what's one of the biggest risks for people at home? Falls.
Falls.
Where do most falls happen? In the bathroom.
And I think you hit on something. You talked about people's dignity staying intact. And we all have a certain level of pride, right? You have a healthy ego, I think, and so maybe you can expand on that, both of you, in your given worlds. In that, again, this difference between the standby and the hands-on, and that whether what's best for you as an individual is staying in your home or going to a facility. How that this person really can maintain their dignity, that you're really just it's like preventative maintenance. Why not leverage this opportunity? Why wait till it's too late type of thing? So you could talk a little about that and what you kind of see in both of your worlds with regards to the hands-on, the standby, and how maybe you debunk for people when you're having conversations some of these myths and some of these, the apprehension that they have.
I think at the point where they reach the need for long-term care, they are in a place where they know they need that care. Okay. Their dignity is maintained by giving them privacy, yet being their caregivers and showing them the respect they need to meet their needs. There's a continuum of care. You start at one level and slowly progress into the next. And I think by that time, it's just a gradual process, and all we can do as caregivers is make them as comfortable as they can be, in those whatever settings required for them.
Makes sense. Anything you want to add?
Yeah, and I think the key, because I'm often in a position of helping, people make the decision: do I transition to this type of community? And I think those communities are great, but sometimes I think for the senior, it's better the devil I know than the devil I don't, and there's a little bit of a scary component. So again, you have to just sort of step back. It's kind of there, but for the grace of God, go I. How would I want someone to help me through that? And sometimes we can even do it on a trial basis.
Right.
So they don't feel, this is a big decision. But what I love about these continuing care communities is they still have their privacy. They still have their own place, and we kind of emphasize that. And they're able to, access the different levels of care because there's that infrastructure in place.
Right. Yeah, I think sometimes people wait too late. I'm not disagreeing with what you guys both shared, but I will push back a little bit on that dignity piece. I know just in my experience, we don't always see maybe our shortfalls in life, our personal shortfalls. There's an old saying I kind of live by, which the key to success is knowing your strengths and your weaknesses, right? So you can surround yourself with people to complement those strengths and weaknesses. But also, I think you need that trusted advisor to point out your blind spots. And I feel sometimes, again, we don't see our blind spots. And as you age, it's like that person that doesn't want to give up their driver's license, give up that car, that freedom, because they really do believe that they can handle it. And sometimes it takes someone like you or a loved one that they trust to say, hey, listen, this is because we love you, and this is a great next step. So I think it's important to have that narrative.
Oh, absolutely.
And change the optics for them.
And it's funny, I often will say sometimes when people need care, it's as plain as the nose on their face, because they're the only ones that can't see it.
Right.
And
actually in the state also, and when they enter the long-term sector, which is the nursing home setting for our people, the state has actually to approve them for level of care in a nursing facility. So they can kind of designate that level of care and where they fit in each community as well, even if the person hasn't identified it themselves.
Okay. So with these senior living communities, have these done anything by way of decreasing the overall healthcare expenses for individuals that need this service? Have you seen that trend in the industry in your world?
It's kind of hard to gauge because they're not receiving those services in their home.
Okay.
So you're looking at 24-hour care, 24-hour access to the different things an individual may need in the different care settings. So to say, the risk of them falling, as she had previously mentioned, you could save a lot of dollars, not, incurring the costs of a fall, whereas you have this preventative care in facilities such as ours.
So that's interesting. I think it's a great point to bring up, which is you can do this in your home.
Correct.
But sometimes, depending on the professional that you have in your home, they're not going to pick up on maybe some of these slight changes in your overall health. Whereas if you're in a facility with professionals, maybe you could talk a little about what types of professionals are in for example, your facility, in your world. They can pick up on things sooner, and it's like preventative maintenance. It's making sure we address things sooner as opposed to letting it kind of just get worse and worse. Does that make sense?
Absolutely.
Okay.
And in our facility, we have RNs. We have physicians who come and visit. We also have certified nurses' aides, and the residents are monitored ongoing, 24 hours a day. So if they're noticing changes, and people get to know these people and know what their needs are, know what their behaviors are, and if they identify those changes, they're used to them. So people can pick up and send them for a hospitalization or for a test or what have you, just to make sure that nothing's gone wrong with this patient.
The resources are there and available, as opposed to being in the home setting, and it becomes a little more cumbersome for the process.
Well, I think one of the issues with really trying to understand the statistics with home care is, number one, there's a tremendous amount of uncompensated care, and that's the number of hours that families and friends and neighbors put in that aren't in those statistics in terms of how much care is actually, and I can't remember exactly what the number was, but it was huge if you were actually to compensate these people for that help. The other thing is, you really can't get statistics unless the person is hiring through a home care agency. Very often people will hire friends and neighbors or someone else to help provide the care, and there's no documentation of that. So it's hard to know what the real numbers are.
Right.
I know I have home care clients that are spending between $10,000 and $15,000 a month because they want to be at home.
Wow.
That's a lot of money.
Well, you bring up a good point, which I think is kind of provocative, which is, I would only imagine with my parents, for example, right, that I'd want to be there and be very hands-on and help them during that stage, if you will, or phase of their life. But I'm not trained to do that. So it's almost, I think we have to almost, again, change the optics for ourselves, which is, yes, we want to be there. We want to give our time. We want to, to show them that we love them, right, by actually walking the walk. But are we almost hurting them in the long run? Because we're not a trained professional. And if you can, utilize someone that's trained in the home or in one of these communities, how much better for quality of life and how much longer can they have that better quality of life? But if we can be more proactive, right, and more preventative, as opposed to, me with my parents that, I don't know the first thing about them, their health, physical, mental, spiritual, and how they're progressing. So does that make sense at all?
It does. And I think another thing, when you're dealing with your family members, it's difficult sometimes to care for that mom or dad, especially if you're...
And be objective, right?
Exactly. And with home care, as you had said earlier, they're only there a couple hours a day. What if, mom needs services in the middle, and those needs can't be met?
And how do you even know if there is that middle, right? If
exactly.
you're not there.
Exactly.
It's hard to identify, I would
Right.
imagine.
Right.
So again, we've talked about the various options. We've talked about the costs. We've talked about some of the funding options. So the million-dollar question is, how do you make your money last? In the context of this care, with all of the various options, how do you make it last?
I think you need to be placed in the appropriate care setting to begin with.
Okay.
You invest early. Eileen has talked some about long-term care insurance policies. That definitely would extend your resources because the room and board is paid for, and then you're reimbursed to a certain degree for those services, which is different than your primary insurances that we earlier discussed. They have to be care specific, whereas this is your room and board. This is reimbursement for medical care.
Well, like you said something, I don't know if you picked up on it, but it was young, starting early.
Yes.
And that's something I'm a big proponent of, and we talk a lot about on Money Sense with our viewers, which is when it comes to finance, when it comes to preparing for the future, your biggest ally is time. And so I think people need to realize that it's, you kind of hope for the best, plan for the worst, have a plan, and then over time determine how we could enough fund this plan. So can you maybe share a little bit about that? And maybe how long-term care insurance can play into that?
That's your area. I'll let you
Okay, sure.
speak to that.
And it's funny because we see more and more people in their late 40s and certainly early 50s looking at long-term care insurance. And by far, when you have the ability to plan, it really is the best option. The way you trigger the benefits is that your physician certifies that you need that standby assistance that we talked about with 2 of those activities of daily living. And as I said, bathing and dressing are usually the first 2 people need assistance with.
2 ADLs,
2 ADLs, yeah. And they're the easiest to manage in a home care situation because they can be scheduled. And I can just give you an example of care management clients that I have. And it's the husband that needs the assistance. And we have a gal that goes in from 9 to 12 in the morning. The wife has already gotten breakfast, but the husband needs that standby assistance with bathing and dressing. but it also covers assistance with what we call homemaker services.
Okay.
So the girl will throw in a load of laundry, make sure the morning meds are done, after helping him with his bathing and dressing, and gets him through the lunch hour. There's 3 hours right there. They're fine during the afternoon. In the evening, another girl goes back from 5 to 8. She'll put away some of the laundry from the morning, helps him back into his night clothes, does the evening grooming, gets him through the dinner hour, cleans up after dinner. There's another 3 hours. But I think a lot of people don't understand caregiver stress. The stress on the primary caregiver. Now, when I do a home care assessment, I very often don't want the spouses helping with bathing and dressing. And I'm sure you've seen this in your environment too.
Exactly.
Primary caregiver's health deteriorates. Think about it with bathing and dressing, there's a lot of twisting, there's a lot of turning, there's too much risk for injury.
Good point.
So a lot of times people think, oh, well, I'll be there to help my spouse. What we want to do is take the heavy lifting off of them, because you said it exactly, it's preventive. These are preventive things. But 3 hours in the morning, 3 hours in the evening, that's still 6 hours a day of care. And at $20 to $25 an hour, you're still looking at $30,000 to $40,000 a year. And that's just basic care.
I can imagine, as my wife and I get older and we face this at some point, it's easy to say again, I want to be that primary caregiver because I love you. I want to show you, again, though, reframing how we think, which is you're still going to be there.
Right.
You're still a caregiver, but do what's best for you guys as a unit over time into the future,
Right.
so that both of your health can be as good as it can be for as long as possible.
The long-term care insurance is just an option that families have.
Right.
Again, in other
Exactly.
words, to have another mechanism in place. It doesn't replace what families do.
safety net,
It just
exactly.
helps them do it better, longer, and safer.
Maybe succinctly, you mentioned, we both talked about starting early, being young. You mentioned 40, 50. Is there an ideal time you should start if you do want to look at and utilize long-term care insurance? Is it like, you should start in your 30s, you should start in your late 20s? Is there a certain time with the policies that are available, the premium amounts, et cetera?
I would say that you were on it at 40 to 50 years old.
Okay.
That's probably a good time in life to assess that.
Okay.
You also made a point earlier that people are living early, or people are living longer.
Right.
Therefore, when people are being taken care of by their children, they're older.
Right.
And we're seeing a lot more of that. And it's deteriorating those people who are at their retirement age and looking to, prosper in their lives outside of the working. Therefore, I think
definitely earlier. The other thing that is really important to consider is that long-term care insurance, it's age and health related. So the younger you are, the less expensive it will be.
Right.
But also, you want to get it when you can still get it.
Right.
If sometimes with different with underwriting. And underwriting's gotten a little bit tougher over the last couple of years because we've obviously had so many different things happen.
Issues.
Issues.
Couple minutes left. So one thing I definitely want to touch on is, if one of our viewers is looking to maybe a senior living community, what are some things they should look for? What advice do you have for them?
I would suggest that the websites reflect the level or the quality of care that's given at those communities, and make sure that they choose settings that will meet their needs. And as I said, the state will assist you with that to a degree, but only utilize the services you need at the time, and your costs are associated with that. So
in 10 seconds each, real quick, and then we're going to get to our final, maybe any last minute key advice, but is it cheaper to stay at home?
Depends on the level of assistance that you need. Again, as your care, just like any setting, as your care needs grow, so too is the cost of your care going to grow.
Interesting.
Absolutely, I agree with that.
Okay.
And she talked $10,000 to $15,000 a month. I said long-term care, 24-hour care, runs around 7 to 8.
I think that's one of those misconceptions that people think it's just, if the home's paid for, I don't have a mortgage, so it'd be cheaper to stay home as opposed to one of these communities, and it depends, it may not.
But $20 an hour times 24 hours a day can get pretty expensive.
Wonderful. Well, thank you guys so very much for being on the show. That was really interesting and very dynamic, so I appreciate it.
Great.
Yeah. And thank you for joining us today. I hope you learned as much as I have. We look forward to seeing you next time for a new episode of Money Sense. I'm your host, Anthony Contrucci. Remember, I always try to make finance fun.
This program is made possible by PSCA, the Plan Sponsor Council of America. For over 60 years, PSCA has served retirement plan sponsors through education, advocacy, and research. Information at psca.org or at 312-419-1863. This program was produced by Lakeshore Public Media and Centier Bank.